and thank you for joining us today. Many changes are taking place to our lives due to COVID-19. We all have experienced the stay-at-home stressors. The social distancing has reshaped how many of us go through our daily experiences. But the virus has also forced unanticipated changes to healthcare practices. And some of those are very difficult on cancer patients and their caregivers. My name is Melissa Niederman, and I'm a longtime volunteer for the American Cancer Society. Today, I have joining me Dr. Judy Jackson, who is the Director of Radiation Oncology at the Comprehensive Cancer Center at Desert Regional Medical Center, and Dr. Mark Jennison, who is the Gynecologic Oncologist at Lucy Curci Cancer Center at Eisenhower Health. They're here to discuss the impact COVID-19 is having and has had on cancer patients in our community. So thank you both for joining us today.
No problem.
Before we get started though, I just want to remind everybody watching that cancer hasn't stopped, but neither has the American Cancer Society. And we rely on donations from people like you. We want to continue the work to help cancer patients and their families in our community. So we're asking, if you can, go to cancer.org/donate local and give whatever you can, because every dollar really does count. So in advance, thank you for your donation. So let's get started. Dr. Jennison, I'll start with you, and maybe both of you can answer all the questions that I ask. I'll just start with one or the other. So first of all, how has COVID-19 affected how you treat cancer patients day to day?
So as you mentioned, Melissa, we've seen change that's been challenging for everyone. And as we mentioned before we started, the one thing that's been consistent for us is uncertainty and change, because we're all learning as we go. And as I've thought about the context of this for our cancer patients over the last couple of weeks, it's almost as if the virus has served as a metaphor for what our cancer patients' journey is. You know, people ask us, what's tomorrow going to be like? What's next month going to be like? What's next year going to be like? We don't know. But at the same time, we don't know. We have this remarkable effort of collaboration, and this venue and the American Cancer Society's work, as well as the collaboration of all of our national organizations, has really served to guide us with taking all of the best knowledge that we have together available in uncertain times and break down the component parts of the questions that we have and the uncertainty and what's new, and help us to develop the best strategies for addressing our day-to-day changes. And for our cancer patients in particular, helping them know that we have a strategy to address what are the biggest changes that might impact on their care, and empowering them with that knowledge and knowing that they're supported not just by one of us as a doctor or in one of our centers or our hospital, but there's collaborative efforts starting, you know, internationally with the World Health Organization, and in the US, working collaboratively with the CDC, and then all of the specialty organizations, the AMA, the American Society of Clinical Oncology, our radiation oncology colleagues have several national organizations, all have working groups specifically for the virus. For us with the Society of G1 Oncology, we've had a working group that's been convened for about 2.5 months that does webinars and updates for us on a regular basis, and has helped us collaboratively and collectively address the issues that we're all experiencing internationally, then learning nationally, how do we tailor that to what we're seeing here in North America and the US, and then for us in the state of California, what are our specific issues, and then narrow that down to our community in Riverside County, and then for us in the Coachella Valley. And ultimately, we've learned how we then take all that information and then tailor it specifically for any one of our individual patients, and then look at the component parts that might be impacted on with their day-to-day care.
And Dr. Jackson, obviously, as Dr. Jennison said, there's so much uncertainty with this pandemic. How is it affecting your day-to-day, and what is the #1 question or common question that patients are asking you about COVID-19?
Since this started way back beginning of March, there's a lot of fear. A lot of fear related to the virus. And unfortunately, at that point, we only knew what was happening in New York. You know, what had come over from, well, actually, it was more like Italy and then Spain. And then we saw New York hit. And we could only provide them the reassurance on what we were doing to protect them. We also, all of us saw changes in our hours, changes in what we could have for surgical schedules, what we could set up for our patients. So there was a lot of changes that we had to sit down with them and their families and reassure them that even though these changes were occurring, they were still receiving their expected course of therapy. And also our research patients, we were still able to get those research drugs. Because I know on the East Coast, they did not receive a lot of the research drugs that we still have very actively going as far as our research protocols. But it was a lot of reassuring that the families, because then what happened after that was they wanted us to limit all the visitors that came in for our patients' treatments. And that was horrifying for our patients. So we really sit down, tried to figure out which patients we could not do that with. We had to have an accompanying person with them. I would call family members who were waiting in the car outside for certain treatments just to reassure them, because they wanted to be part of the conversation with their spouse and their loved ones as what was going to happen, what would happen next, or what was their progress at this point, even if it was a follow-up. And we weren't able to do that. So we would actually go back to my desk. I would call them right away. And that's what we established, was all these chains of communication with not only the families, but the patients also, of course, just to reassure them and reassure all.
So that is something that I was thinking about. I'm dealing with a little bit with my mom now, and I can't go into doctor appointments with her. So you are allowing some caretaker or caregivers to come in depending on the situation. Is that the same?
It actually, the hospital, my hospital is backed up and said they will allow one visitor. That visitor has to have no fever, no symptomatology, of course, that would be suspected of COVID, but we are allowing at least one. And it's not just, I mean, people even going upstairs to get just hydration. They still get other medications. They need help. They're a little bit fuzzy, maybe a little groggy. They need someone to help direct them and say, what did the doctor recommend? Or when am I due back? And those sort of things. They just get basic questions answered for home care. Right. But we are doing that. We have to.
Right. So Dr. Jennison, are you having the same experience, having maybe to calm people down because they can't have someone in the room with them?
Yeah, I think our patients are uniquely prepared to deal with the uncertainty piece, but what has really been a change is, as Dr. Jackson mentioned, is for them to be flying solo. I've got a patient who's been in the hospital since the beginning of March, and she has a daughter who lives in the Bay Area. She has a sister who's helped her through her course who lives locally, and she hasn't been able to see them. And the rules and how and when we allow visitors has been tailored to what the incidence is in your community, what's the hazard of any one visitor, and the risk that they might be an asymptomatic carrier walking into your institution. So how and when visitors can come is tailored to particular circumstances. Talk about courage that I see every day when I walk into that room, and you know, and occasionally we'll FaceTime together with her sister. Flying alone for a lot of these important moments has been really challenging, but we've also learned of the wonder of FaceTime.
Right.
You know, to be able to tangibly see somebody, really, really important. One of the more touching circumstances that I've engaged was a patient of mine who's was married for 62 years, and her husband was home, isolated. He's 98 years old, and they had two caregivers and the patient. And somehow he contracted the virus, and he spent his time in our hospital, his last days in a room, isolated. His primary care doc came, Dr. Mamo came and fed him personally 3 times a day. And then they Zoomed and they FaceTime. And that FaceTime was so incredibly meaningful for the patient, her husband, and their family. And so this mode of communication that we're doing, I think, is one of the durable benefits that our society, I think, has plugged into. You know, I connect more with my family who's back east. I have elderly parents in Santa Fe and Chicago, homebound. My 93-year-old father and 88-year-old stepmother have not been out of their 1,200 square foot apartment, other than to go downstairs to get the mail. And there's a grocery store downstairs. They had not been outside. They opened the door, their balcony on their sliding glass door, and their balcony doesn't work as well as it might. And so they've been housebound, but they have meals with, you know, their grandchildren. They get to see their great-grandchildren through this great venue. We've celebrated holidays in a fashion we never thought of doing together. So this technology has actually been one of the, one of the unintended benefits of the
Right.
virus, because as you're alluding to, the sense of isolation in day-to-day treatment has been something that has been
Right.
challenging. But on the other hand, if you think and you prepare for somebody who feels alone sitting in a treatment chair or about to get their radiation treatment, or is in a room with us, to have their family member there that they can see, to FaceTime them, is something that's bridged the gap, I think, in a way that has been really helpful.
Right. Right.
That I've really seen with my patients, and unfortunately I've got a lot of patients who have like Android and don't want to download the app because they're afraid of viruses, they're afraid of this, and we've had to really encourage them to please download this so that we can see each other. I can look at their treatment area, we can discuss things, because there for a time we were hardly bringing anybody in. We were doing everything on, just video chatting. But what we've really found, and this has happened probably, I would say, in the last 4 weeks, the people that have said they have to come in because they're so depressed. They are so very lonely. And I have had more patients just be so tearful. And mostly we just talk. We talk about their cancer, but we just talk. They just want that interaction. And they're so sweet. They ask, can you hold my hand? I'm like, well, of course I can. We can do this. Yes, I can hug you. And we can make some of these exceptions because they've just not been touched by anyone for over a month or more. And it's devastating. So
Yeah.
devastating.
It seems like it's caused you, the doctors, to have to really go outside of the box of what you usually do. I mean, you usually have somebody there listening to the diagnosis, to whatever test results, but you don't. And so now you have to be the one almost like holding their hands and trying to get this information to them. So.
That's true. And it's taking a lot longer, which is fine, but we're just taking that time because they need them. My nurse sets with them. We set with them. Even my front receptionist sets with them and gives them that time just to be able to talk or relate.
So
Yeah.
if you, I mean, are you seeing people who are in the hospital and by themselves much more depressed than usual? And if so, do you go towards that technology to help them out?
We do. Yes, we of course we get them to video chat. We have actually computers on the floors too that can be moved around so that patients can utilize that. But no, we are seeing a lot more depression. I'm actually addressing it medically too with medications and stuff, just to make sure, and actually trying to get counseling. I can get video chat counseling from either our psychologist or our social workers to talk with them, and that's invaluable.
Yeah, and then for our patients who've been in the hospital, who are either in the ICU or in one of our COVID units, who are either have tested positive or they're awaiting their test result, there is this sense of isolation in the room. Instead of having, a warm, caring body come to greet them as their nursing provider, their nurse's aide, their physicians. We're minimizing the contact of the providers for the patients. That's kind of a two-way street. And then the providers are coming in, they're gowned, they're wearing a mask, frequently there's a shield, and it's this sense of sterility. And then the providers, and at times when the patients really are at risk for in transmitting the infection to us, keeping the providers out of the room as much as possible has been able to be manageable by having tablets with our patients. So we FaceTime with them on their tablets, but we're not there. It's not the same thing as being in the room. And so then we have this fine balance. When do you take the extra time to utilize the PPE, expose yourself potentially to the virus in their room? And so we have this kind of fine line that we really try to manage. And to me, one of the more inspiring incidental aspects of this has been our staff on the COVID units. Really amazing. The amount of our nurses on our surgical floor, our former surgical floor on 4 East has been turned into the COVID unit. And a good number of our staff who've taken care of our post-operative and perioperative patients for years are now COVID nurses. And the caring and concern that they've provided, that we get the feedback from our patients, has really been notable, and doing the best they can in their best Florence Nightingale way to try and provide that extra comfort and care for the patients.
Wow, that's actually, hearing all this is reassuring to me, knowing if someone in my family has to go in. It's good to know, to hear this from both of you. Now, because of the fear, and perhaps a patient is not in the hospital but has been told they need surgery, or some type of treatment, but they went, no, 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 I'm going to put it off. How do you deal with that fear? What do you say to them? Let's start with Dr. Jackson. I don't know if you've dealt with that yet.
Oh, no, we have. We've already dealt with it probably months or two ago. And in the respect, we have to start with the patient, what their disease is, what their stage of disease is, and we have to educate that patient and their family to understand that. Yes, we've had, and just as Jenison was saying, is we've had a lot of our national medical committees come down with schematics, our scenarios that how we could take a stage 1 who has an ERPR positive breast cancer, and we can put them on anti-estrogen therapy for a short period of time while we wait to get them on the OR schedule. And so those sort of things we're looking towards. Can we put people on Lupron with advanced prostatic cancer to get them fitted into a schedule? Because the big thing is they have to get to surgery. We have to get them treated, and they have to be treated appropriately. We don't want to take that risk to potentially see more advanced disease down the road. And I know they're afraid, and we try to reassure them with, again, our PPE setups, our isolation, how we're taking care of them. And also our patients are all being tested before they enter the hospital to make sure that we don't just happen to have a COVID patient coming in to infect.
How about you, Dr. Jenison?
Yeah, so again, we've benefited much, as Dr. Jackson's alluding to, from guidance from folks who sat down and did rapid modeling to try and so that we can individualize for our patients, whether they're at a low, intermediate, or high risk for delay in their treatment. And the same has been done for chemotherapy patients, depending upon the diseases they have. And for us with surgery and cancer surgery and surgeries in general, the American College of Surgeons has worked collaboratively with our national organizations. And so for patients who might require surgery, they're stratified into 3 categories. They're at a low risk for postponing the surgery for a month or 2, and intermediate risk or high risk. If they're high risk, this all happens in the context of what is the incidence of the virus in your community and your institution at any one point in time. If it's like New York and you're at NYU or Mount Sinai, nobody got operated on because they didn't have the resources, they didn't have the PPE, they didn't have the physicians, and their resources were all directed towards the acute illness of the COVID patients. They were only able to operate on patients with emergent surgical problems. So if you had ovarian cancer, you had a biopsy obtained from a metastatic site and started on chemotherapy, hoping to build a 2 to 3 month bridge, after which hopefully the environment in New York was going to be safe enough for them to have their surgery. If you had an early stage endometrial cancer, you got treated with hormonal therapy for 2 to 3 months in the same spirit. If you had ovarian cancer that needed to be mitigated, you'd have to, they'd have to prioritize that based on what was happening with other emergencies. We've been really lucky in our community here because we had somewhat delayed exposure, I think, to our community, and because of the early interventions that we've had in the state and the county and the Coachella Valley and our institutions trying to stay ahead of things, we haven't had the same incidents and the same trauma and challenges that they've had in New York and Seattle, and we've been able to benefit from their experiences. So this has all allowed us to tailor the treatment interventions for radiation oncology, surgery, and then also medical oncology. If a patient needs to be started on chemotherapy, who needs it now, who can wait, as Dr. Jackson alluded to, who can get hormonal therapy as a bridge. Fortunately, we've been able to see things at least plateau a bit now. That has allowed us a little bit more latitude here to have treatment as we ordinarily would more frequently than if you were in New York or Seattle 2 months ago.
Wow. It seems like you are, maybe this is the way it's always been, but you seem to have a lot more communication and back and forth with other hospitals, other doctors throughout the country. Is this something new, or have you always been in contact talking about whatever procedures or treatments you need, Dr. Jackson?
I think we've always been in contact. We're talking about our therapies, our research, like a lot of the research studies, how they were going to proceed, as primary investigators and such. We've always had the ability across the nation to be able to do that. I think what's different now is that we're actually really coming together to share treatment options for acute care. And that's something that I've not had to have a part of, but we all do now with COVID-19, is that we're able to share that information, share what has worked, what hasn't worked, what are some of the new options for testing coming out, the new antibody testing, and so forth. And I think that has been a nice collaborative effort, between the doctors in Louisiana to Seattle to New York.
Right. So when this pandemic is over, do you think that the way you're treating your patients now might even go the same way in the future? Or, I mean, do you think it's going to be any different, or will it go back, quote unquote, normal?
Well, to reference Yogi Berra about predicting the future, it can be a little tough and challenging. I think that's one of the things that, again, that we're all experiencing when patients ask us, okay, when's my next appointment going to be? How many televisits will we do until it's safe for me to come to the office? What the televisits actually have done for us is allow us to lessen the density, the number of people who are coming to see their providers who might be asymptomatic carriers. So for anybody who really needs to come see the doctor, it's created a much safer environment, and we're very comfortable with patients coming in to see us when they need to. And so I do think that that one of the durable gifts of the virus will be, one, when you're at a time where you have limited resources, you become more resourceful and more thoughtful. How much telemedicine plays a part of our future, we'll have to wait and see. I do get the sense that from a collective standpoint, and please remind me when we're done, guys, wrapping up, about kind of a metaphor for the American Cancer Society, reminding us of the best of the human spirit working collaboratively towards a common goal. What we've seen with the virus for us medically is we live in somewhat of an altruistic bubble. So we don't need to really worry about getting reelected and all of these other issues. We live in an evidence-based world where the patient in front of us is always our priority. And so we've had all of these organizations in this collective effort where we were previously in parallel silos working towards the same goal. But we've had to be more connected now with our radiation oncologists, connecting with the medical oncologists and the G1 oncologist, et cetera, with our nursing colleagues, with our administrators, with our infectious disease colleagues, and public health. I think the public health piece is the one thing that's been missing. And to just share a quick anecdote, my daughter, you all should know, full disclosure, Dr. Mrs. Niederman, inspired not once but twice. She had her 2 years as a teacher, and inspired her to write and to open her mind to what the possibilities of the world could be. And so she was fortunate enough to have a State Department grant and be in Taiwan last year, the year before the virus came. And what she learned about the sense of collectivism that happens in Taiwan because of the common cause that they have there to preserve thousands of years of their sacred culture. Now everybody prioritizes that, and the wonder of what they do collectively together every day really created an enduring gift for her and for our house. And this year, looking at what's happening, with our challenges that we have in managing the virus, and not coincidentally, places that have a sense of collaboration over common goals, like Taiwan, South Korea, and Australia, they've managed the virus in really a way that we could all learn from. And part of that is prioritizing public health. I think we have a blind spot, and as Mrs. Snyderman knows, for many years, we have a gap in science and technology education in the U.S. We're behind a lot of the developed world with that. And part of what we're seeing right now with our national conversation, I think, has revealed that we will do better in the future with helping folks to understand things like public health and why it's important to understand some basic fundamentals about science.
Wow, that's true.
One thing I wanted to add to that, in respect that, I think what we've seen more in these last couple of months is just even more humanistic for our patients, much more connection, much more. I'm like I said, I walk out and I see one of my patients sitting with my receptionist, and they're just talking and talking because that person has no one to go home to but maybe a puppy or a kitten, and we're just seeing that a lot more. Maybe we have a more open schedule, so we have the ability to do that more so. But it's so nice, instead of being so rushed, we're really able to take those people who truly need to sit down and provide them that support and their family.
Yeah, and in that spirit, one of the more notable, palpable changes with the televisit, instead of a patient having to drive to our center, get transported to our center, sit in the waiting room, come into our exam room, sit in the exam room, then have us come in, I'm talking to them when they're sitting in the comfort of their recliner or in their den or wherever it is in their house. And the sense of focus and engagement is at a different level than we see in the office. It was really one of the first things that I noticed has really stood out about the value of the telemedicine visits. The environment a patient has at home is obviously a lot more conducive to honest, open dialogue without the added apparent edge that we're seeing now is so much more evident when we've seen patients in the office. So I think that may also be one of the durable gifts. There's certain venues now where I'll be able to I think have better dialogue with patients when we can just do it in that environment and not have them, have them be as on edge as they were if we were in the office.
Wow. I love to hear through all this ugliness, just that the beauty of the compassion and seeing something in the future that could be a good thing with the way that you are talking to your patients. So I love to hear that. Thank you for that visual too in my mind. We're almost completed here with our conversation, but I do want to remind the people who are watching, you've heard both of these doctors talk about so many different aspects of fighting cancer, especially in a pandemic. So what we need you to know is that this takes money. It does take money, and the American Cancer Society is right here willing to help. And we need your help because that's what we go by. People like you out there watching us who are compassionate. So if you can, go again to cancer.org/donate local. And remember, any amount makes a difference. So we really appreciate that. And as we wrap up here, I didn't know if either one of you had something you wanted to add or make sure that people know about that we haven't really touched on. So I'll start with Dr. Jackson. Do you have anything that you wanted to add or bring up?
I just want to remind patients and their families that we're here. We're here, we're available. We're still treating all of our patients. No one's been turned away. Maybe we've had to adjust people to reduce the flow, like we were talking earlier, Dr. Jennison, but we're here. Call us, come see us, let us help you. And don't worry, we would never set an environment that wasn't safe. We want that for our patients always.
Yeah, I would just reinforce that, and that's beyond us. And one of the things that the American Cancer Society has always, that I learned from when I became engaged by the American Cancer Society in about 2003, was that it kind of represents the best of this collective effort. And when people talk about me and limited resources, with there's G1 oncology shortages all over the United States, it's never just been me in the Coachella Valley. I'm here as part of an ocean full of waves of G1 oncologists all over the country that have been connected, that are on a regular basis sharing our experiences together. The American Cancer Society has always been kind of a palpable coalescence of the approach that we have as physicians, and then for you all who were not trained healthcare providers, who get it because of whatever experience you had, kind of merging those two worlds and creating a link and an informational link to give patients a sense that this is bigger than any one patient, any one doctor, institution. American Cancer Society really has represented a noble cause to bring the best and fill the gaps that our care providers really have needed as partners.
Great. Well, thank you so much, Dr. Jennison and Dr. Jackson, for your time, for everything you do, for your expertise, your compassion. On behalf of the American Cancer Society, we really do appreciate everything you've done for our community and all who need you here. And hopefully, things will get a little better soon and it'll be a little bit easier for you guys. But in the meantime, thank you again.
We'll all still be here. Thank you.
Right. Thank you. Thank you, everyone. Take care.
Thanks, guys.
Yeah, thank you for your time and engagement, guys. Appreciate it.
Thanks a lot. Bye, buddy. Take care.